Top Med Talk.
Hi, it's Monty Mython here, Editor-in-Chief of Top Med Talk. Well, these are extraordinary times. Despite all the challenges we face, we will continue to deliver free, open access medical education for as long as we can manage it, as well as our new regular updates on COVID-19, the global pandemic of coronavirus. Reporting from the front line, we'll be concentrating on enhanced surgical recovery. Why have we made that decision? Well, with an unprecedented pressure on resources, many institutions have decided to accelerate their widespread adoption of enhanced recovery. And why? Well, it's never been a more important time to reduce complications, readmissions, avoidable ITU bed occupancy, and to get our patients home fitter and faster after major surgery. As somebody who's about to get back into the trenches in critical care, to all my surgical, anaesthesia and perioperative care practitioners, thank you for making this a priority. A big shout out to our sponsors, in particular Edwards Life Sciences, who have very generously agreed to continue to support this resource, that's Top Med Talk, at a time of global need. We're all in this together. We will get through it. It's going to be fun.
Our next presentation, which is from our colleagues across the water in the Netherlands, multimodal prehabilitation to prevent post-operative delirium and other complications in elderly patients after elective major abdominal surgery. And Dr. Janssen is going to be the speaker.
Good afternoon. First of all, I would like to thank the organization for allowing me to present to you our research from Breda. We prehabilitated elderly patients to prevent post-operative delirium and, well, as you can read, other complications. Viva Pharma sponsored intravenous iron injections. Well, most of you have probably seen this already. It's more or less the same in the Western European countries. But this is the age composition in the Netherlands. In the left graph, it's 1990. And on the right, it's 2050. And as you can see, the number of elderly patients is increasing rapidly. And with the number of elderly patients increasing, the number of age-related diseases is also increasing. And one of these age-related diseases is delirium. And delirium is the most frequent complication in the elderly surgical patient, with very high incidence rates. The variation is quite wide, but over 50% of elderly patients develop a delirium after colorectal cancer surgery, elective colorectal cancer surgery, and 22 to 39% after surgery for abdominal aortic aneurysm. We did a study in 2015 in our hospital, and we found a delirium incidence of 15% for both conditions combined. So why is that a problem? Delirium leads to, first of all, there's a risk for increased mortality, an increased risk for institutionalization. People with delirium are more prone to develop dementia. The length of hospital stay is prolonged, and there's considerable healthcare costs to be taken into account, over $150 billion annually in the United States. So we wanted to prevent that, and we hypothesized that it would be possible to lower the incidence of delirium by prehabilitating elderly patients prior to major abdominal surgery. What we did, and what others did in a Cochrane review, was they looked at interventions to prevent post-operative delirium, and they found that multi-component interventions were able to actually lower the incidence. So that's why we wanted to implement a multi-modal prehabilitation program. And we set up the AUTO study, which is a Dutch acronym and is roughly translated as a preoperative optimization pathway for elderly patients. So what did we do? We sent these patients to a physiotherapist who gave them exercises to perform at home, unsupervised. They had to walk for 30 minutes or ride a bike for 30 minutes daily if they were not able to walk. And they had to perform muscle exercise training. First of all, respiratory muscle training by doing 2 times 50 minutes of resistance training for 3 times a week. And those same days they had to perform 5 leg muscle exercises to increase the leg muscle strength. All these exercises were tailor-made, so in case of frail patients, they were given easier exercises depending on their own strength. We also sent them to a dietitian who gave them advice on protein and calorie intake. And they needed to have a protein intake of 1.2 grams per kilogram body weight daily, and a calorie intake of the basic need plus 30%. Basic need as assessed by the WHO. And in case they didn't meet those requirements, they were given supplements, as in proteins and vitamins. In case of frailty, they were sent to a geriatrician who performed a comprehensive geriatric assessment. And in case of frailty, that means when they were cognitively impaired, when they had delirium in history, when they had a timed up and go test with a physiotherapist of longer than 12.6 seconds. And in case of polypharmacy, more than 5 types of medication used, they were sent there. So they assessed the entire health of the patient again. They checked if they could cessate any medication, and they gave advice on whether to give them prophylactic haloperidol during admission. And in case of anemia, patients were given 1,000 milligrams of Ferinject to increase their hemoglobin levels. And we aim to do this in 4 to 6 weeks prior to surgery. This would be the optimal time. So we did it in the Amphia hospital, and we set up a before and after trial. We had a historic cohort of 360 patients, and we made power calculations that we wanted to decrease the incidence of delirium with 50%, and therefore we had to include 275 prospective patients. Inclusion criteria were 70 years or older, and they had to undergo elective surgery for abdominal aortic aneurysm or colorectal carcinoma. And they were excluded when they were acutely admitted, when they needed acute surgery, when surgery was planned within 2 weeks of the multidisciplinary meeting, or when they had surgery within the 6 months prior to this admission. Our primary aim was to reduce the incidence of delirium, and secondary aims were to reduce complications, readmission rate, to reduce the length of hospital stay and mortality. So, as you can see there, we included 267 patients. 395 patients were eligible, were assessed for eligibility, but 77 patients did not want to participate because they were either fit enough or they had to come to the hospital already too much. So these are the baseline characteristics. And as you can see, is that the burden of comorbidity was higher in our prehabilitation group, both for ASA score and the Charleston Comorbidity Index. Also, our prehabilitation group was more physically impaired and visually impaired. And our prehabilitation group underwent more laparoscopic surgery than open surgery. So what we did, we first checked that the incidence of delirium, and what we see is that in our control group we had an incidence of almost 12%, and in our prehabilitation group we had an incidence of more or less 8%, which would be a decrease of a third. And after adjustment for important confounders found in previous research in our hospital, we found a significant decrease of the incidence of delirium. Unfortunately, the prehabilitation program did not have any effects on all other outcomes. So what we can conclude is that prehabilitation can effectively reduce the incidence of post-operative delirium, and unfortunately, the current program did not have any effect on additional complications, readmissions, length of hospital stay, and mortality. So what to do in the future? I think it's important that we identify important precipitating risk factors for delirium, which we can tackle in our prehabilitation programs. And it would also be important to assess which patients are most frail and are most likely to benefit from a prehabilitation program. And long-term outcomes of this study are coming soon, 6 and 12-month follow-up. Our follow-up closed in the previous month, in June, so to be continued. Any questions?
Thank you very much, Dr. Janssen. That was a really interesting presentation. I'd like to start the questions with maybe a simple one, and it may be a resource issue. What sort of physiological improvements were you able to track? I mean, they've done, broadly speaking, some fitness work, for example. Did you do a walking test or any strength assessment? Or you just assume maybe they got fitter?
Yeah, the latter. Yeah. So we didn't test that. We felt that the burden for elderly patients was already high enough, so we didn't want to give them any more tests. And previous research pointed out that supervised exercises can actually increase fitness. So that's why we didn't check that.
And there are a couple of questions on the use of haloperidol. Would you like to comment on that?
Yeah. So I asked our geriatrician in our hospital as well, and she said, no, there's no evidence for it, but they feel that it maybe doesn't prevent delirium, but at least it'll make it less long and less severe. So we give it, and it doesn't do any harm, I think, in most cases, and maybe it helps. Yeah.
And a final question relating to the potential value of cognitive screening for, I guess, inclusion in the program.
So everybody had a MMSA test, a mini mental state examination to check for cognitive impairment. We didn't include or exclude any of the patients, but that's one of the outcomes we're also investigating in only the prehabilitation group is cognitive impairment and the effect on quality of life.
Okay. Thank you.
You're welcome.
Nick Majorison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.